two, to provide our community with options for treating pain. So I will kind of guide right into this. All right, so as Dr. Brown alluded, I'm Sherry Gopaul. I'm a board certified family FNP, and I'm with Commonwealth Pain Management and Wellness here in Henrico County. And tonight, I just want on our agenda, we want to talk about pain.
Excuse me real quick. I'm sorry. Go up to where it says slideshow across the top.
Oh, thank you.
And then you can do from current slide.
Current slide.
To your top left there.
There we go. Excellent. Okay.
Thank you.
Thank you. Is that better?
Yes, perfect.
Excellent. I want to talk a little bit about the epidemiology in pain, the opioid crisis, the different types of pain that exist, along with treatment options and alternative modalities. In our country today, the epidemiology, I'm sorry, that's a typo there. It is estimated that the prevalence of chronic pain ranges from 11 to 55% in our population, which we approximate to over 100 million Americans. The true chronic burden of chronic pain is not fully understood or estimated. However, we do know today that back pain is ranked the #1 reason that people seek care, along with other musculoskeletal disorders being ranked #2. Since the year 1996, up until 2013, it has shown that we have spent around $87.6 billion in healthcare expenditures caring for people suffering from chronic pain. And as a result, chronic persistent pain can lead to significant psychosocial health, physical impairment, as well as reducing performance of social responsibility, like including work and life, family life. And so I want to talk a little bit about the crisis, as we talk about all the time, but in our community, I don't feel like practitioners discuss the risk and the crisis that our country is in as a whole. But there have been 3 waves of rise in the opioid overdose. And this is a pictogram directly from the CDC that describes sort of what transpired starting out with the year 1999 with the first rise in opioid prescription overdose. And then you can follow the timeline here where you see that the second wave of opioid or overdose and death is risen from use of heroin. And then that is followed by a third wave of synthetic opioid related death. And when I say synthetic, it includes illicit manufacturing of fentanyl, which can be combined with substance like cocaine. But according to this diagram, you can see here that synthetic opioids still remains the #2 cause for deaths, followed by heroin. And I want to sort of bring that down to how does that relates to Virginia. Well, this chart shows you here color-coded by the number of death by states. And while Virginia still falls within the mid-range, we are still seeing a lot of overdose and death related to use of synthetic opioids and fentanyl. And again here, for our state of Virginia, we still have the same numbers as we just described. So what does that mean? What are we doing nationally and locally in our state? Well, nationally, the CDC work with practitioner researchers and across states. One, to improve the data, how we support our providers and our healthcare systems with the tools and evidence-based guidelines to improve our decision-making on improving opioid prescribing, because there is still a role and a significant place for prescribing opioids safely for the management of chronic pain. And then second, we're advancing research to collect and analyze data on overdose and taking that information to improve the quality of data we have so that we can identify areas for prevention as well as education for the public. And one of the other things that is being done is increasing public awareness, which is really what this talk is all about tonight, about opioid prescription overdose, misuse, abuse, and overdose, and how we're making it safer for patients. So I really want to go into the different types of pain classification, because not all pain are equal, as I tell patients. And these are the subcategories that I'm going to briefly talk about here from the standpoint of how it is felt and how it is treated. And so acute pain is referred to short-term pain that's lasting no less than 3 months, no more than 3 months. And it's typically caused by a specific factor, such as an acute injury. You're riding your bike and you fell off and you kind of got a ankle fracture. Surgery, soft tissue injury, broken bones, cuts or burns. Also folks who are going through childbirth and labor. And for these types of pain, pretty much you can either remedy that with some kind of medication or a minor procedure, and they typically heal and the patient is back to functioning in life. The second type of pain is chronic pain, which lasts more than 3 to 6 months or greater. Chronic pain affects 1 out of 5 American adults. And it is often the cause caused by underlying issues and can often be associated with injury or illness after healing has occurred. It can be linked to arthritis, nerve pain, fibromyalgia, headaches, and many other conditions that can cause chronic pain. Neuropathic pain is often specifically caused by nerve damage or other parts of the nervous system, like spinal cord injury, or also it can be caused by someone suffering from diabetes, like diabetic peripheral neuropathy. It can also be caused by a condition like post-herpetic neuralgia from shingles in the older population. It is a common type of pain. It can be intermittent, meaning it comes and goes, or it can be lasting and notwithstanding. Symptoms often patients describe it as feeling as shooting, stabbing, burning, or pins or needles in their hands or feet. Sometimes in their face, sometimes it can be a truncal area. And it can also cause by sensitivity to touch, and also caused by unregulated feelings such as hot or cold sensation in patients as well. Now, nociceptive pain is a pain that is caused by damage to body tissues. It can further be subclassified in 3 different categories, such as radicular pain, which typically occurs because of irritation to nerve roots in the arms or leg, such as what we can say a pinched nerve in your back, that we call it lumbar radiculopathy. Somatic pain is a pain, it's receptors in your tissue, such as your muscle, bone, or skin that are activated. An example of this is a typical headache or migraine. And then visceral pain is typically caused by injury or inflammation to your internal organs, such as your pancreas or liver or an internal organ. Now, nociceptive pain is often caused by external injuries such as bruising, burns, sprains, bone fractures, bumps, things like that. And this is sort of a diagram I wanted to share with everyone tonight to sort of give you a picture of what it looks like when you have a painful stimulus, such as you pricked your finger. And as you can see in this diagram, you got an injury to your finger. The pain travels primarily what we call nociceptors. It travels through the spinal cord, what we call the dorsal ganglion root. This gets transmitted through the descending pathway to our brain, what we call the limbic system or the thalamus. It interprets the pain. And now pain perception is really interpreted in our brain. And it can be what we say, everyone interprets pain differently. No two people feel the same pain level. And this can also be contributed through how we were raised, our cultural upbringing, our background, what we were taught, male versus female. In some cultures, pain is a sign of weakness. In other culture, we're taught, well, if you have pain, something is wrong and you should seek care. And so the way we perceive pain is different to everyone. And it is why our care is individualized to the need of that patient based on their underlying pathology and what is causing their pain. And then back to we interpret that pain, and then we send a signal wherever the injury is to remove ourselves as a stimulus so that we don't cause further damage to the body. So I want to dive in a little bit into the treatment options, specifically for long-term chronic pain. Most often, a person or a patient who have had an automobile accident or injury on the job, or they're playing sport and they tore their meniscus, typically they will be taken to an emergency room. Surgery, if medically necessary, will be performed. They're given medication post-operatively, whether that's opioids, typically includes some form of opioids. With non-opioids, they're treated, and then they're discharged home. And from there, the patient is sent to an outpatient clinic such as ours, where we may initiate long-term care, or they just may need a couple months of treatment, and then they're back to recovery. So treatment options for long-term pain includes the following. Acetaminophen or Tylenol is always one of the safest drugs to use till this day. It is a centrally acting non-opioid. The dosage that most practitioners will utilize starts at 325 milligram all the way to 4,000 milligram per day. That is the maximum dose. And we do that because Tylenol can cause, it's toxic to the liver and can cause hepatotoxicity, as well as hypersensitivity, which means a reaction to it. Anaphylaxis is where someone can have swelling of the throat or the tongue from taking a medication or substance that their body will react to, and not in a good way. And then we can also see some nausea, vomiting. Tylenol is still a very safe option for women of childbearing age, as well those who are pregnant, and also for mothers who are lactating. And so we use Tylenol very frequently, both in the acute setting and the outpatient setting for pain management. Another medication or class of medication is called gabapentin or gabapentinoids. While we don't know the exact mechanism of how this works, we do know that it blocks calcium channel blocker, which modulates some of that neurotransmitter I just showed on the previous picture of how it's transmitted. And so it blocks some of these excitatory neurotransmitter, whereby inhibiting pain. Standard dosing, we start low and go slow when it comes to gabapentin. At 100 milligrams all the way up to 3,600 milligrams max dose daily. It is indicated for neuropathic pain specifically, diabetic neuropathic pain, post-herpetic neuralgia from shingles, and fibromyalgia. Adverse effects with using or starting this medication can be depression, Stevens-Johnson syndrome, which is like having a really bad rash that's all over your body, swelling of the throat, and then withdrawal from abrupt discontinuation. And then we come to the classification of NSAIDs or anti-inflammatory non-steroidal anti-inflammatory. And in this classification of medication, it includes ibuprofen, naproxen, and Celebrex, what are the common ones mostly prescribed. There are many others to talk about, but in lieu of the time, I'm just going to stick to these few. And again, NSAIDs inhibits what we call cyclooxygenase inhibitors that thereby reduce prostaglandins, and which causes inflammation. And by reducing inflammation, you reduce pain. The dose is really dependent on what the particular medication is used. This classification of drugs are usually indicated for osteoarthritis, rheumatoid arthritis, and mild to moderate pain. One of the major side effects of using these drugs includes GI bleeding, ulcer, and there are some known cardiovascular risk. And we use these medications when patients are typically monitored. We start at the lowest effective dose and then tailor or titrate it to the effect of pain relief while monitoring for adverse reactions and getting blood work. Another class of medication that is commonly utilized in pain management is muscle relaxant. Some of the drugs include in this class tizanidine, Flexeril, baclofen, and Soma. Soma is not commonly prescribed, but it is a very effective drug as well. And these meds work by binding what we call central alpha adrenergic receptors. Thereby, they reduce spasticity, which is a common issue with muscle spasm, and they're indicated for that. And again, these are dose dependent on which medication is prescribed. And then adverse reaction we can typically see with starting a muscle relaxer is sedation is the most common side effect. Typically, I started in patient at bedtime because most patients who have pain have trouble sleeping. And since this medication is good with helping and relaxing the muscle, it also helps the patient to sleep. And then we work to adding dosage to the effect of the pain. And then we come to opioids. When we talk about opioids, it's a whole different process and guidelines. There is a safe way to do it, an effective way to do it, with including monitoring, screening, adherence, and looking at treatment compliance in our patient. Opioids are a class of drug that specifically bind to opioid receptors, thereby producing analgesia, and it also produces sedation, meaning it makes people pretty sleepy at times. Opioids include medications such as oxycodone, morphine, OxyContin, and hydromorphone. It is indicated for moderate to severe pain. It is used both in the acute inpatient setting as well as the outpatient setting for long-term pain management. And usually I and most practitioners will initiate opioid at the lowest effective dose and titrate it to the patient's pain level, functioning, psychosocial functioning, and getting that patient back to life. The common adverse reaction you find with the class of opioids that we prescribe outpatient is respiratory sedation sometimes, nausea, vomiting, constipation, and sometimes people become dependent on these medicines. And so it's very important that practitioners who are prescribing these medications discuss the risk and benefits with the patient, and always consider other alternatives. And we also have to measure that the benefits will always outweigh the risk when prescribing an opioid. And then alternative modalities or treatment options for chronic pain, which we also incorporate in our program, includes physical therapy, aquatic therapy, which we give a patient a prescription and they may have a physician-guided program to help with pain control, whether we're looking at longstanding arthritis or knee pain. Mostly patients who have major joint pain can benefit from aquatic therapy. Dry needling is another good option, as well as acupuncture. yoga and meditation has been shown to improve how people perceive pain and respond to pain in their daily lives. There's also a thing called pain psychology for patients who need help with coping with long-term chronic pain as a result of an injury or a trauma. Many times we find in my personal practice and lots of research that has been published, many patients who suffer with chronic pain also suffer with chronic depression or anxiety because pain inhibits their quality of life. A lot of times they are not able to work. So it affects their social settings, their family, and life as a whole. So sometimes pain psychology can be very, very beneficial for a patient who has had underlying comorbid mental health issues that is connected with their pain. And then there are interventions such as injections, pain pump, and stimulators that we don't perform here, but are done in the community and can be done very effectively. In addition to interventions, the last resort for some patient is surgery. Most often it's orthopedic surgery that involves a knee or hip replacement, a shoulder replacement. And sometimes it's something else if it's an abdominal related condition that someone might need to have surgery for. And so what we do here with our program is work with those patients to get them the appropriate referral for the appropriate care that they need. And then lastly, I kind of want to come back to the discussion surrounding managing pain with opioids. And as I alluded to in the beginning of this talk, there are significant risks associated with treating patients or the general public with these medications, but there is a need that also is not being met. And some of the data has still shown us that there's a growing need for pain care, especially in our community, but there's limited access to care. And most practitioners have, because of the incidence of overdose and death, specifically from illicit substances or illicit fentanyl use, most practitioners have either discontinued their practice or have turned to alternatives. And that has left a gap in care, especially in the Richmond area, but most of the area like Emporia or the Hampton area or other areas such as Fredericksburg, that you don't see clinics that are able to provide this level of service to people, where one, they have an understanding of the benefits and risk of care, and two, they're appropriately monitored and ensuring that they're complying, but also offering alternatives to patients that they may usually not hear about through a traditional practice. And so again, I just wanted to bring this to the forefront that there is such a thing as medications that are high risk and treatment options, but there is ways to treat pain safely and effectively while allowing people to return to function and returning to life. And so I will this is a pretty short discussion. I wanted to make it brief for you all, but I will sort of open the floor for questions and what may be a topic of discussion.
You all
good
may
evening.
unmute. Oh, go ahead, Dan.
Okay, I have a question. In your practice, do you write prescriptions?
I do.
Okay. You mentioned something I've never heard of before. Of course, there are millions that I've never heard of before. But you mentioned that there are people who take 4,000 milligrams per day. What kind of patients?
Yeah, I have treated many patients with Tylenol. It's really 4 grams of Tylenol. I've treated patients both post-operatively after surgery. In fact, Tylenol has been shown to help reduce the amount of opioids we use in patients that are post-surgical. Someone who just had major abdominal surgery, or someone who had a joint like a hip or a knee replacement. In fact, it has significantly reduced the amount of other medication that we utilize for pain control.
So you said 4 grams. Did I misunderstand you when you said, I thought I heard you say 4,000 for some people per day?
So it's milligrams. So 1 gram is 1,000 milligram. So 4,000 milligram equates to 4.
I got you now.
Yeah.
Right. Okay. I got you now. Okay. Thank you.
You're welcome.
If there are others with a question, please unmute, or you can put your question in the chat room and I'll read it.
I have a question. Is there any focus on ensuring that opioid addiction, opioid abuse, is there a development for a database to ensure that patients aren't being overprescribed? I guess that's the question I have, to help prevent some of the overdoses that we're seeing.
Absolutely. So we utilize what's called the Virginia Prescription Profile, which is a central database for our state. Nationally, most states have a centralized prescription monitoring program, it's called specifically. But in our current practice here, we have the ability to pull that information. So what that means is that every time a patient is given an opioid, or in my case, every time I prescribe to my patients, I will run that profile to make sure that they're not getting it from me and, 3 other practitioners in the state. Now that is state dependent. It rarely crosses state line. And we do know that the DEA is working to create a profile that is more nationally recognized, so practitioners can see if a patient is traveling to Kentucky and they're getting prescription opioids, but then they're coming to Virginia and they're also getting opioids. So we have the ability to see it across state line. Currently, we don't have that mechanism, but we do have any prescription that's given in the state of Virginia, I am able to see that. And that's, in fact, it's one of our criteria for compliance, that the patient is accepting it and consenting to receiving opioids from our practice and no other practice. They sign an agreement to do that. And then we monitor with other labs to follow up. So that is in place to ensure compliance and to reduce the risk of multiple prescribers and overdose.
Thank you.
You're welcome.
I see a hand raised with Ms. Quarles.
I just had a question. I know you said everybody feels pain differently. I was just wondering, have there been any studies on why some people who have surgeries with, extreme surgeries with pain become addicted and others do not?
Well, while there's still many publications to address that specific question, we still don't know today the exact mechanism of how some patients can feel pain with a minor procedure while others do not. And what we think or postulate is that it really boils down to the ability for someone to experience and their tolerance level. So what we do know is some people have high tolerance to pain, meaning they don't experience the same level or intensity of pain, versus some people have very low tolerance. When it comes to addiction, it's, there's many publications to discuss people who have familiar or family lineage of addiction. And so that's one of the things we screen for. Have you been dependent or have a history of any kind of substance use? And that can prelude someone to, okay, well, we may want to talk to this person about, well, what are their options? And then further get appropriate screenings, whether or not this person is at high risk for opioid addiction or abuse. And those can include anything from tobacco, alcohol, cannabis, gummy, CBD, anything of that nature. In addition to that, another screening tool we use here is looking at depression and anxiety. Depression primarily. Patients who have underlying untreated depressions are most likely to have a very difficult and prolonged course of pain control. And so we make sure we try to assess and use all the tools that are given to us to minimize that in patients.
Thank you.
You're welcome.
Yeah, that was kind of, I was looking at the title and you said pain management. I know most people would see that, but the and wellness, part of what you all do. So I would assume, like you said, you're seeing people who have a lot of pain and you're trying to get them off the pain meds. How long would you guys typically continue to see a patient after you, wean them off of pain management and deal more with like the wellness piece, I guess?
Yeah, so we do twofold. One, we see patients who are coming to us to initiate pain care for long-term management, and all the things I talked about in this presentation will be offered to that patient for continuation of care. We see patients who have gone to other practices, but for one reason or another, they're coming to us to continue their care, whether that provider has retired, or they don't accept their insurance, or it's a convenience of availability. It could be various reasons. But I also wean patients off of opioids and transition them to non-opioid based care, including physical therapy and the other modalities that we discussed. So we do treat patients with both opioids, non-opioids, and then physical medicine such as therapy. A lot of times what we do with some of our patients, will treat them until they are well enough to look on the wellness side. And those things include referral for medical weight loss, or as simply as getting on an exercise regimen for weight loss and overall health, including modification of their diet.
Thank you.
You're welcome.
Good evening, ma'am. I have two questions.
Absolutely.
What is the difference between dry needling and acupuncture?
So acupuncture, dry needle is more specific to that muscle or that area of pain. Acupuncture is more generalized, and I share this with you because I've had it done personally. And so what the practitioner will do is place needle on different trigger points or trigger areas of the body. But putting a needle in the shoulder can also help different areas of the abdomen if you're having pain. So dry needling is more specific to the particular area of pain, while acupuncture is given, and it's more generalized when it's placed on the body for treatment.
Okay, thank you. And my next question is, if back pain is the #1 chronic pain, do you advocate the wearing of a back brace?
I typically do not advocate back braces, and the reason for that is wearing a back brace has been shown to cause muscle weakness from longstanding wearing a brace. What I usually advocate is to put my patients into physical therapy to strengthen those core muscles, which reduces your pain long-term, but not necessarily to wear a back brace.
Thank you.
Welcome.
Getting back to the opioids, many times on a weekend, we've read about, we've known people to go out and take, we don't know how many. But what is a person's, is an individual thing as to, I may be able to take one and it doesn't bother me, and another person take one and they die. What is the difference? What do they?
Yeah. So there's two things to that. There's an opioid naive patient, which is somebody who has never been exposed to opioids before, and it's their first time taking that medication. It is the very reason we initiated, we start low and go slow. Start at the very lowest possible dose to monitor for side effects, sedation, and any risk factors in that patient. A patient who may take 5 milligrams or 10 milligrams and they're okay, sometimes they might be opioid naive, but a lot of times they are opioid tolerant. And that means they have had this medication before in their system and they have incrementally added on or titrate that dose that they can tolerate. And that's what we mean when we say we titrate to the effect of relief of the patient. And for that very reason, we never want to prescribe a really high dose of opioids to somebody who has never had that in there previously, because in that situation, you're really going to jeopardize the health and well-being and put them at increased risk for sedation and death. So typically we don't do that. Most patients will be able to tolerate a very low dose opioid, such as 2.5 to 5 milligrams of oxycodone, or you can start with something like tramadol, which is a very, very weak opiate. It's like next to Tylenol. So you kind of monitor that patient and how they're doing. And then you can add on or titrate it based on how they respond to that in order to minimize the risk of overdose.
Thank you.
You're welcome.
Dr. Gopaul, you mentioned Emporia, Virginia. Is there a higher rate of opioid addiction in rural communities? Or, what are the numbers looking like for Virginia overall, rural versus suburban?
Well, I don't have the numbers in front of me on rural areas. Virginia is still considered in the medium risk for people that are dependent or addicted to opioids. But what we do know, states such as rural areas in Virginia, in states such as West Virginia and Kentucky, have the highest rate of addiction and death. And that's primarily based upon a couple of factors. I'm not sure how familiar you are with the Sackler family and when OxyContin was invented back in the 90s. They targeted states like West Virginia and Kentucky because of their states where people didn't have jobs that are, what we call white collar, blue collar jobs. There are states where, you had coal mining or labor intensive job. So we targeted those places where we knew people didn't have access to proper education, to understanding of the risk and benefits of opioid. But they had a higher rate of injuries because they were doing more labor intensive work. And you find that as well in rural communities. Community members don't have, they can't afford to send their loved ones to college, or they themselves weren't able to do that. So, they work 2-3 jobs that are very labor intensive. So they're at a higher rate for hurting their back or hurting their knees, having neck issues or shoulder injuries from heavy lifting. And so you do find a higher incidence of addiction, abuse, and misuse in those communities where people don't have access to these things, such as the mainstay we call society of an education and a good job where it doesn't require a long hours of work, and it doesn't require working 2 or 3 jobs to maintain your family. So while I don't have the numbers, I can tell you that that does exist in those communities.
Wow, thank you.
You're welcome.
Could you tell us a little bit about cortisone shots, please?
Sure. There are different types of cortisone shots. You can do a cortisone, which is pretty much, it's a steroid. In some cases, we can put in an anesthetic, such as lidocaine. And it is typically injected in what we call an intra-articular space, such as a knee or a shoulder. And it is done to reduce inflammation that's typically caused by some type of arthritis. Osteoarthritis is the main one. And we perform that procedure to reduce inflammation, swelling, and pain. And it's more of a conservative measure to help the patient to return to function as long as they possibly can without delaying surgery. Because ultimately, if you have severe osteoarthritis of your knee, most often it'll require a knee replacement or a joint replacement. Sometimes we do it in the bursa or the hips for the same reason. The only concern or the consequence of steroids in the joint is kind of twofold, because while you have arthritis and you're coming in for treatment, when you put steroids in the joint, it also causes bone deformity and arthritis. So it's sort of a double standard there. So we typically don't put it in the joint more than less than 3 months, and probably prescribe it 2 or 3 times a year for that reason. I hope that answers your question.
Yes, ma'am, I did. Thank you very much. It seems like each time my mother go to her primary care physician, he hitting her in the knee with a cortisone shot. But you just said that a person should get no more than maybe 2 per year.
Typically no more than 3 per year.
Are there other questions? You may unmute or put your question in the chat room.
Yes, I have a question. Is acupuncture accepted by insurance?
Typically not a covered modality with insurance. Most places you pay for, the session. Now, I previously worked at VCU, or Virginia Commonwealth University, where we offered the service for about $50, $60 per sessions, but most insurances don't cover acupuncture. But we did find out that they will cover chiropractic therapy.
Thank you.
You're welcome.
Anyone else this evening?
My last big high-level question. So with the pandemic, have you guys seen an influx of additional patients that we think is going to have some link to the psychological effects of this, or not really? Pretty much steady from what you saw pre-pandemic?
So to answer your question in a nutshell, yes. And that's primarily based on many providers are retiring because of the pandemic.
Okay.
It has caused much, hardship on their own practices because they're not able to see patient in person. But to tie on to that, many patients who have had chronic pain and could not get the care that was needed have now worsened. So on top of having limited access as a whole before the pandemic, now it's extremely exacerbated because the rate of depression and anxiety has significantly increased along with pain, just because of the sheer fact that people could not get access to care.
Thank you.
You're welcome.
You all see Ms. Gopaul's information. If you cannot see it, this has been recorded, so we can easily get you the information. And Ms. Gopaul, we thank you so very much for your presentation on tonight and helping all of us. And we want to tell everyone to please have a great evening. And we will see many of you all on Wednesday for noonday or evening Bible study. Take care, everybody. You can unmute.
Thank you all for joining me tonight. I appreciate your
Thank
time as well.
Thank you.
Thank
for your time.
you.
Thank you.
Thank you.
you.
Thank you.